Hello, everyone. My name is Shadi Reis. I'm from Detroit Medical Center, and me and my partner, Andrew Goldswag, he's Associate Professor of Medicine at Nebraska University. We're putting together the CCI Cast that's going to be coming to you routinely, highlighting a feature article from CCI Journal. We are delighted today to have Dr. Stephen Bailey. He is the editor-in-chief of the CCI Journal, and he's going to be discussing a topic of the CCI Journal for this month. Dr. Bailey, the floor is yours.
Shadi, thank you so much. What a pleasure it is to be joined by Elisa Alton from Yale on behalf of her colleagues talking about seasonal variation in U.S. hospitalizations for chronic limb-threatening ischemia.
Yes, absolutely. My name is Elisa Alton. I'm an assistant professor at Yale, interventional cardiologist with a focus on endovascular intervention and chronic limb-threatening ischemia.
Well, I want to congratulate you on the topic and the manuscript that was published in CCI. The fact that you looked at seasonal variation, I think, as we enter the height of winter this year, is something that is on top of mind for many of us working with patients who have this condition. And I know that you used a very focused NIS database in the era from 2012 to 2015 to make sure that you captured the data with as much fidelity. In looking at in the analysis you did, one of the striking features was the difference in geographic distribution of patients. I noticed that or a significant minority, if you will, roughly 40% of patients, came from the South. And I found that quite interesting that there were such large variations regionally. Could I have you comment on how that might be and how that might influence your conclusions?
So it's a really important question. The variation we see in the number of patients in the South likely reflects some of the increased risk factor exposure, specifically diabetes, CAD, hypertension, et cetera, that exist in some parts of the stroke belt. Certainly, amputation rates in certain part of the South are quite high. Your question in particular, though, is if we're seeing a late winter, early spring preponderance of admissions for CLI, how does that relate to the relatively warmer temperature seen in the South? So this is where there's some limitation in the database. NIS gives you broad geographic regions, and the states in the South include places like Florida, where there's less temperature variation, to places like North Carolina, where there's maybe closer to a winter season. This initial observation in the clinic that led to this hypothesis and this paper was actually made in a conversation that I had with a podiatrist who had previously only worked in Miami. And his observation was there was no seasonal variation. And we had noticed that our clinics were so quiet in the fall. And he had never experienced that in Florida. So I suspect if you drum down to the state level data where you can get better meteorological temperature variations and more narrow range per state, you'd be able to really more clearly assess the variability.
Well, I think as with all good studies, yours in particular, there are a lot of hypotheses and opportunities for investigation. That's clearly one of them. I do note that you confirmed the seasonal variation for ACS in sort of a 8 to 12 weeks difference in the CLTI incidence as well, but still with seasonal variation, at least across this database. You did also point out that there seems to be some relationship to influenza, and I wonder whether, since there is marked differences between diabetic and non-diabetic populations, if you had a chance to look at the impact of a strong influence of influenza on that in terms of these patients.
That is a really important suggestion. We did not pin down the difference between diabetics and diabetics with regard specifically to influenza. In this database and in this study, we recapitulated findings of increased influenza in the fall and the winter, and that probably leads to the excess of winter mortality that we see in this and other studies similarly. But specifically looking at diabetics as a pull-out group, we did not.
So I think one of the questions that I took away from this is, in our focused endovascular clinics, our limb ischemia clinics, what might we think about doing differently in these individuals? And I wondered, have you done something differently? Are you looking at tissue oxygen tensions? Are you, doing any other testing in individuals you feel to be at highest risk? To prospectively identify patients prior to their presentation?
Well, certainly paying a lot more attention to the toe brachial index is something that this study has highlighted for me. And of course, that's something that we consider in all our patients who have PAD, but that gets to be a real estimate about the perfusion at the distal extremities. And the distal extremities seem to be most at risk from the vasoconstriction from the cold. Certainly, I think there's a lot of translational work that can come out of this, specifically looking at cold response testing in limbs that are more threatened than others. Mm-hmm. And hopefully those will be the subsequent studies to come from this.
Well, in the COVID-19 era, as we're facing now going into the winter, I'm sure that you've already begun looking at that as a potential even more intense driver of systemic inflammation that may impact these patients. And so we'll look forward to centers like yourself and clinics like yourself as we begin to think about that thrombotic potential we're seeing with COVID-19 as well.
Thank you very much. And it's great to have this conversation with you and start thinking forward to where we'll go with the next study.
Well, it's great to have you on CCI Cast, and we look forward to your next submission to CCI. Congratulations. Happy holidays.